Having an illness and have to go out of your country with another language, with another people, is very hard.
طبعاً ابتعد عن الأهل والأقارب وارتباطات العمل.
The culture, the environment, everything is different.
Al decidir viajar, confiamos mucho en los resultados, pero también teníamos miedo.
GPS helped us transition from India to US. They understood the complication, made us aware of the changes that we are going to face when we are in different country.
They make the communication with the doctors easier. I mean, they arrange everything, the admission, the paperwork.
The staff from the Global Patient Service gives a lot of emotional support. They can share stories with us to make us feel less anxious.
With my mom, the help was incredible. The moral support, explain to her what happened, be with her when I was in a surgery, explaining everything when you are in an appointment.
لو تحدثنا عن القسم الدولي كان أيضاً متعاون من وصولنا إلى هذه الدرجة إلى اليوم اللي احنا ممكن نغادر بعد فترة قصيرة.
We were asked by a visa officer, do you have any relatives or friends in US? And the first name come to my mind is a staff's name from Global Patient Service.
GPS did holistic approach in making us feel that we are taking care of you as family.
Somebody was always available there for us. We never felt that, oh, we are from different country.
Cleveland Clinic is a place that I can call home, family, and the Global Patient Service help is incredible because now I feel I'm Clevelander.
Thank you very much. That's certainly always a very moving video to watch and one that I enjoy. And do want to welcome Dr. Nizar Zein. He is chairman of Global Patient Services, as well as Dr. Maan, who is vice chairman. And both of them have been incredibly wonderful and supportive to C3 from New York to Saudi to China. So with that, Dr. Zein, I'm going to turn it over to you. And again, so grateful to you and all of your staff and colleagues at the clinic. And as well, Dr. Heba, thank you. Who's been wonderful. Are we moving over to Dr. Zein?
I apologize, I was on mute while talking. All right. So I'm going to make a quick disclaimer that the video we just saw was created before the COVID pandemic. So you see few people hugging each other. We don't do that anymore. Right? Thank you so much again, Ransel. Thank you, Ghassan Abu Alfa, our colleague in New York. Thanks to Sam Palmucci, thanks to all the staff of C3. We are honored to be invited to join this meeting. I attended all the meeting yesterday and some of the meeting today, and really it is very impressive. And while it is virtual, I think there are a lot of things we're going to learn from doing virtual meetings that in the future maybe C3 will evolve into both in-person and virtual meetings all year long. So the title of our panel is Adapting to Changing Patient Needs, Demands, and Expectations. When it comes to healthcare, members of the millennial generations have really already turned the delivery model of healthcare upside down. They grew up in a technology-powered consumer environment where in that environment, transparency, rapid delivery, and convenience are the norm, are the expectations. Look at ordering through Amazon. It's a classic example. they want these same expectations to be applied to healthcare. So people are asking, why would the experience be so much better, quicker, transparent elsewhere and not in healthcare? They want a good outcome, but they want also all these expectations to be fulfilled. An example in healthcare is that millennials have recently created this wave of abandoning the traditional primary healthcare model in favor of ease of access provided by retail giants like CVS and Walmart, where they have perfected over time the ability to provide a happy consumer experience. This shift has created really shock waves and dilemmas within traditional healthcare, like our organization, in which how can we still provide the high quality and good outcome of healthcare that we are known for, but also do it in a different way, in a way that would fulfill some of these new expectations. Then COVID-19 comes along. And while COVID-19 did not initiate these changing expectations, but it certainly have accelerated many of which. So these are the issues we are going to be talking about today. I am honored today to say that I am joined by really true, esteemed and highly knowledgeable colleagues of mine. The first of whom is Dr. Heba Abdulrahman Alqurashi from Saudi Arabia. She is the head of Health Informatics Department in the College of Health Sciences in Saudi Electronic University in Saudi Arabia. I'm very excited to hear Dr. Alqurashi as we move forward with this panel, in part because we heard a lot about changes within Saudi healthcare system. We heard about a little bit about Vision 2030. We heard a lot about the NEOM project yesterday, but we have not heard enough about education sector, and this is where Dr. Alqurashi expertise lies. Second panelist is my lifelong friend and colleague from Cleveland Clinic, Dr. Maan Ferris, a highly accomplished cardiologist and a vice chair of global patient services at the Cleveland Clinic. With this introduction of the topic, I'm gonna turn the panel to both Dr. Ferris and Alqurashi to make comments. Maybe start with Dr. Alqurashi. Probably help us set the stage to what we are gonna talk about. We talk about changing needs, expectations, and demands. But can you shed a little bit more light on what's driving these? What are the drivers behind the demand to change the way healthcare is being delivered today? And while some of the things may apply to one country than another, but the fact that human experience in healthcare is universal, many of the topics we're going to talk about are applicable universally. Dr. Heba, the stage is yours.
Okay, thank you so much, Dr. Nizar, and I really appreciate the very happy and positive introduction. Actually, everything that you've mentioned is correct, and I believe the previous presentation that was conducted by the Ministry of Health covered quite a lot with regards to how the digital care is actually, how the new technologies and the movement towards everything being more digitalized and more into technology does affect what's happening now. I do have a quick presentation, if I may.
Sure, absolutely.
Just okay. Okay, I'm not sure why, but it's not working, but I can still cover for it. So what is happening right now with everything that you've mentioned? There's a lot of changes that are happening in healthcare, whether it has to do with how consumers are moving more towards technology, but at the same time, we have the population is aging, and that's a direction that we also need to take into consideration. Other than the whole population and what's happening now with the pandemics and the epidemics that have happened the past few years, there's also a move in healthcare towards quality and accreditation. And these things, with the changes that are happening, they were the trigger for Vision 2030 to happen. And it led to many changes occurring in the kingdom with regards to, we started our own national accreditation organization called Sibahi. They've mentioned quite a lot, so I don't want to repeat it, but we've also, there's also applications that have been used since COVID-19 started. We have more than 5 applications that are just for healthcare, and they're separated from telehealth, to getting your prescriptions, to booking your appointments, to letting you know if anyone around you actually has COVID-19. So this is what has been done by the ministry. And with the vision, there were a few other things other than healthcare, and one of them spoke about human development. The human development program that's part of the vision spoke about providing training and education. It spoke about making sure that it meets with the new developments that are happening. And some of its commitments that were supposed to be met, and some of them have been now because of COVID-19 also to speed it up, by 2020 to actually provide through electronic education, teachers, nurses, and physicians in specialities. Now, the role of the Saudi Electronic University through all of this, because it was actually built to be partially electronic, was that we were able to provide and to help other universities and the community throughout. So we were able to give seminars to educate the population. And that's even one of the things that were mentioned in yesterday's session about the community and how can they help. This is how education could help. We provide seminars, we provide lectures for the public and for hospitals, and the same way for even our students and our faculty. We were able to give lectures. There were more than around 20 to 30 research and publications that were conducted just by the Health Sciences College throughout the period of the lockdown during COVID-19. Now, how does the education sector work throughout this? What happens is this, we depend and we look into what does the market need? And depending on that, we start working things out. So right now, the WHO issued a statement that there's 13 challenges to the new healthcare right now. And from these challenges were to provide healthcare through crisis and conflict countries, to be prepared for epidemics, and we have COVID-19, which we're working through right now, and empowering the workforce and providing for it. And this is where we come in. The university checks what's missing in the market, what is there that the market needs in healthcare. We conduct our research and then we start developing our programs. After developing these programs, we contact the certifying and licensing agencies to be able to certify our graduates. And after that, there are more specialized specialties that we need. For example, and around the world, there's a lack in clinical coders, in clinical documentation specialists, people that are specialized in e-health, m-health, and also in health informatics. And most of these programs, some of them are already offered by the Saudi Electronic University, and others are still under process. So this is where we come in. We do our research, and then we try to provide to fill that gap. So I hope I answered the question.
Yeah, very much. Dr. Heba, before I let you off, a little bit more expanded. So when you talk about, you look at market needs, you do your research, you figure out where are the gaps in training and education. We may need more of nurses, more of the specialty of medicine, and then you create programs around it. Is your market only Saudi Arabia, or you look at a broader region beyond Saudi Arabia for needs? Do you go to the entire GCC market need? Or this is a Saudi project, Saudi focused? And the second quick comment about, it sounds like a great plan, but how did COVID alter your plan? Made it harder to achieve or easier to achieve, or more demand on your education or less demand on your education?
Okay, so for your first question with regards to how do we study? So, yeah, so the market right now, the needs that are in Saudi are almost the same as the other countries. I had a meeting a few days ago with colleagues from Australia, and when I was telling them this is the need that's in our market, they said it's the same in Australia. I got to even speak to some of my colleagues in the UK, it's the same. Clinical coders is very necessary around the world. There's still lack of physicians and nurses, and it's globally. So we do apply it to the Saudi market, but it's when we're talking about that, it's also internationally. Because in the Saudi Electronic University, we don't have only fresh graduates. So our students they have executives, we have healthcare workers, and we have people in higher positions in the country. So we offer our university for everyone. And to answer your second question, and that's how I will link it, so Saudi Electronic University had already part of its development or the learning system that we use is called blended learning. So part of it is already electronic and the other is physical, but most of it is electronic. During COVID-19, what happened is most of the other universities started to need help. How can we were basically doing everything physically, how can we do that? So the university offered help for the other universities to provide them with support for e-learning. We also gave support for Blackboard, which is a system that's used in education, and there are also some other sectors that use that to provide that. For the university itself, we moved fully electronically. So we had our students that were scattered all around the world because some of them didn't come back and return in time. And they were able to conduct their exams electronically, take their lectures electronically, communicate with their instructors the same way. And this is how we were able to do that. And we did a few collaborations with some institutions to do the same thing. We were able to provide backup and support.
Thank you, Dr. Heba.
You're welcome.
Dr. Ferris, when we talk about changing expectations and needs in healthcare, there are some very obvious domains that have been heavily discussed in healthcare. Access, patient experience, price and cost transparency, and quality of care. These are some of the top items. I want to focus a little bit on access. And I think Dr. Heba already very nicely, presented an argument in which education and training can provide can fill in the gap in healthcare when it comes to the traditional model of healthcare, that is a patient going to a healthcare facility to receive care, be met with a healthcare provider, receive the care and go home. This is the traditional way of medicine. But other delivery models have come along, and probably what dominated the scene in the last year or so is virtual medicine or telemedicine as one example of new models of care delivery. Now, when you talk, as you know, we work in the same organization, people are very polarized over the issue of virtual medicine or telemedicine, from ones who believe that it is a suboptimal but a quick fix to the issue of social distancing, and this is a good thing to do, but once COVID is gone, virtual medicine is gone, while others believe that this is going to become a foundation for care delivery in the future. What's your perspective on it? What camp are you in, and is there something in between the two camps?
Well, Nizar, thank you so much for the introduction. And as you mentioned earlier, thank you to Ransel and C3 for giving us the opportunity. And I want to mention that you probably, between you and Heba, you've summed up everything we could talk about in the next hour. But regarding your question and where do I stand, I think for people that assume that virtual health or telemedicine is only a fad and is a temporary phenomenon, I can tell them people were wishing, it's wishful thinking, because people were assuming that consumer buying over the internet for products was only a temporary phenomenon when the internet came along in the 1990s, and we can see that it continues to dominate our life right now, and it has been affected by COVID-19 just as much. I can tell you my first experience with telemedicine actually came from my experience with the prior organization that I worked with, where we realized that we had patients in Hawaii that needed certain specialty care, and in particular dermatology at the time. And there weren't enough dermatologists in Hawaii to meet the demand. And it was not acceptable to have the patients travel from Hawaii to California to be seen by a dermatologist or a specialist. So the answer at the time, and this is 10 to 15 years ago, was to use technology to link the patient with the specialist without having either of them travel via technology. It seemed like a revolutionary idea at the time. However, it met the patient's demand, and it was met by criticism by many people. However, it has grown since then. I do believe that telemedicine is not a replacement to traditional care. However, it is a complement to traditional care. It comes to supplement the need either before a visit or before an in-person contact, or certainly after an in-person contact. We've seen in our own organization the explosion of demand for virtual care now with COVID-19. And although we realize that the demand for telemedicine will probably decrease in the months to come or in the years to come, but it will forever continue to be greater than where it's been prior to COVID-19 because of the increased adaptation. I can go on. I think it's the consumer expectation right now that the quality of life and the nature of the life of the consumer, they can't truncate their day and travel to a main campus, if you will, and spend half a day finding a parking to meet with a pediatrician for 15 or 20 minutes and ask few questions. They realize that all those things could be done much faster, much better, and just as well through a telemedicine encounter with a pediatrician or a specialist, specifically when there is a familiarity with the environment in which they are getting their care. So this is not a foreign interaction for them. I hope that it answers to a certain extent the question that you're asking, Nizar.
Maan, can you comment? This is something really always unclear to me. Is it appropriate? I know there are legal regulations or not, but does virtual care bring down country national borders? Is it appropriate for Dr. Ferris in Cleveland, Ohio, to be providing medical care to a patient in Riyadh, Saudi Arabia, or in Lima, Peru? What's your take on international, doing stuff across borders?
Cross borders. This is a fantastic question, and as you know, you and I deal with this on an ongoing basis. I think what virtual care and our experience with the internet in general has we realized or exposed the fact that technology at times is faster than the regulators. In other words, technology come and then the regulators have to decide, do we make people pay taxes for their transaction on the internet or not? And the same thing happened with healthcare. Specifically to answer your question, it is inappropriate for a physician to practice medicine in a place where they're not licensed to practice medicine, because this will ultimately erode the ability of the regulators to make sure that this person who is claiming to practice medicine is indeed a physician and licensed and has gone through all the requirements needed to practice medicine. On the other hand, I think it is perfectly appropriate for a physician in the future, as we go on, from reputable healthcare organization to collaborate with healthcare providers across borders for the betterment of the healthcare of individuals or a group of patients. So I think it is certainly with the future where physicians from healthcare organizations that are qualified and certified to interact with their colleagues across borders and take care of patients either through a second opinion or a process where they have a meeting. Tumor boards will increasingly shatter the borders, and I think we also will see certainly physicians that participate in things like monitoring patients across borders, or you and I also deal with patients that are coming for transplant, where all the screenings can happen in their country of origin, and then the patient will be selected properly, will travel to where they will get that specific care which may not be available at their country of origin, and will improve better follow-up for the patient as they go back. So the notion of transporter medicine is going to grow and is here to stay as well.
Yeah, so actually part of the reason I thought I'm asking you this question is like many of us, I attend occasional courses online or in person. Now it's all online, and I attended few at major universities here within the U.S., Harvard Medical School and Cornell universities and others. And when you get on those online courses and you meet your classmates as such, you realize that the majority are from all over the world. So in the education sector, we certainly brought down all national borders. In healthcare, probably it's more complicated, but certainly at some point, regulations and understanding how this could be delivered, I think will lead us to path education have been through. Okay, so I am not gonna get you off the hook yet, Maan. One more introduction to so we talked about the demands for certain areas to change, one of which we talked about access. Another is the patient experience. And healthcare consumers are looking again at Walmart, at CVS, they are looking at Amazon, at Google, how they deliver their products. It's not necessarily healthcare, but it can be healthcare as well. But how they can deliver it in a seamless way, in an efficient, and they're saying, how come you guys cannot do it? And that's where patient experience or demand to change the patient experience have come. But it, help us a little bit. What is patient experience? Everybody talks about it. There are ways to measure it. What is in it for us as a healthcare system? Why would we even improve patient experience? So help us out a little bit here, and then we'll take it. Yeah.
So thank you again. This is another question that you and I deal with on an ongoing basis, and we have many discussions. I think as we agree with the general definition of patient experience is really a sum of the multiple interactions that this patient will have with a certain organization. And it's at the end of the day, it's really about the perception of the patient of that interaction or those interactions. And it is not just the interaction between the patient and the physician. It starts way before, when the patient calls a healthcare organization, and how fast do they answer their phone call? How easy is it to get access to their needs? And oh, by the way, how far do they have to travel to get to their needs? And then you go on to talk about the physical experience of that healthcare organization. Is it an open environment? Is it an environment that respects confidentiality of the patient? So it is really a mixture of very complex needs of the patients. And ultimately, the patient is looking at the value of that interaction with this certain healthcare organization. And so the organization is going
Maan, there's a comment that people having hard time hearing you. Can you speak up or get closer to the computer?
Yeah. So is that better?
I assume so. The person who's put it up, Bob Castro. Go ahead, man. It's better.
I think I have my microphone at the highest level, and I will try to improve it a little bit better as well. Yeah. However, as I said, it is this mixture of interactions that the consumer has with a healthcare organization, and at the end of the day, it is a perception. So healthcare organizations struggled in terms of defining or finding out what is this patient perception of their healthcare, and therefore they come up with metrics. And more importantly, governments and payers have demanded to get those metrics, and therefore they initiated surveys such as the HCAP survey and many other surveys where they can actually classify where those healthcare organizations fall within that patient experience and the value of healthcare that they provide to the consumer. Without taking too much time, I think this is where I would like to stand on the patient experience, and we can answer more questions going forward.
All right. I'm gonna switch a little bit back to education, from patient to education. Dr. Alqurashi. So I like to talk a little bit about something that I've been hearing about for 2-3 years, something that is being considered highly innovative, ambitious. So some people wonder if it is too ambitious or not. Mm-hmm. And also transformative, not only for the healthcare in Saudi Arabia, but far beyond that. I'm talking about Vision 2030 as it relates to healthcare. In fact, it's really fascinating to sit through the C3 presentations yesterday and today to hear this theme coming up over and over with ideas that extremely innovative. But once again, can we go back to the healthcare education sector? How do you think Vision 2030 will transform it, or even help me out here? Let's say everything planned is accomplished in the next 1 decade, in the next 10 years. What would the healthcare education sector look like in 2030?
Okay, so some of the programs that were set for the vision itself, and when you sink into the details of it, it talks about moving all of education to be fully electronic. So it's not just about university levels. Right now we're talking about full-on education. It starts from kids, from the beginning of going to education until afterwards, and even for specialized care. This is one of the first attempts that are being done. And I remember yesterday, Dr. Amir from Dubai, he was saying the same thing. He said they've already started with them in the UAE. They've started with education. So this is also one of the things that has been put in plan. Now, for healthcare specifically, it's more about being able to provide not only what is the full-on education, but also to be able to provide like postgraduates or high diplomas that are specified in what is needed right now. So for example, now the people are most in need now for informatics to know more about how can we link this new technology to healthcare. And you as an education sector, we're expecting you to be the link between those two. And that is one of the things that we are doing. It has to start first, because you can't build something in the education sector unless you've done your research. And actually, Vision 2030 helps us with doing that research full on, and then makes us start right away. It talks about everything. The vision talked about even improving how people's lives are, improving quality of life. It targeted different kinds of aspects of the community. And when it comes to education, it clearly discussed in a few different areas and different programs how to target it with regards to training, education itself, and then improving what's going to happen in the future. What is expected is that the education sector wouldn't be working alone. And this is what Vision 2030 is all about. It's about linking all of the sectors together. And for healthcare, right now we're teaching our students a course called Electronic Health Record, Electronic Medical Record. And even in the presentation before that was done by the Ministry of Health, they said we're already starting to have an electronic record for all citizens that cover all kinds of hospitals. That was also a question that was addressed yesterday. So somebody asked the question, why is it only for public hospitals that we have the same record, but private are separated? That's not what's happening now. This is the beauty of it. So we're teaching whoever wants to join our university, we're teaching them all of the aspects that they need for them to be able to be part of this change and help with it. And also in the aspect of telemedicine, when you were talking about it, one of our students she conducted a research with her supervisor. She's one of our master students, and she was trying to target telemedicine specifically, which are the highest departments that are using telemedicine with their patients. And to be honest, for me, it was quite a surprise to learn that surgery was the highest with regards to telemedicine. It was surgery first, and then oncology, and then hemodialysis and pediatrics. The results for me were shocking. I never expected that surgery would be the first. So it's very interesting how education can help with this. And the vision is moving us all forward towards that.
So I would tell you that at our organization, it's not surgery, it is Neurologic Institute that is doing the most in telemedicine. I'm not sure I know why, but the gap is huge. That the Neurologic Institute is doing multiple folds greater than any other institute within the Cleveland Clinic. I suspect this is partly have to do with the buy-in of the leadership within those institute, not necessarily because one sector is more attractive than others. I don't know the right answer.
I think if I may jump in on this last point, I think precisely what you said, the buy-in from leadership, the desire to innovate or to break taboos, if you will. But also we have to realize, even in the United States, or particularly in the United States, the payer model or the payment model also plays a major role in terms of adaptation of certain technology. So for surgeons, for example, it is very common to not be paid for follow-up visits when they know they just need to check on the patient. And I can see that virtual care could play a significant role in that aspect of their care, as long as it does not decrease the quality of care and it improves the patient experience. We've been talking about the patient experience. Why should I drive for an hour and a half and again, go over all the steps that I need to take if I'm only going to see the surgeon for 5 minutes and I can show my wound in a very seamless way and a confidential way over a camera, at the comfort of my own home or from my office at work without taking time off. So again, I think a lot of things we will continue to learn about this going forward.
Dr. Heba, back to you briefly. So I understand a little bit more what Vision 2030, how it drives change in education and other sectors. Can you comment on the role of private sector in this whole thing? Is it all government mandate, government driven, or there is a private sector part of this, or is it a partnership?
Okay, so also part of the vision is to include the private sector. So it's not just about the government aspect of it, it's to work together. That's what I said when I was talking about collaboration. It also included the private sector. One of the programs, so the vision is divided into different programs. And one of them, it actually talks about, it's called the privatization program. And it talks about how to integrate it as part of the whole economy and not just based on governments. And one aspect of that that's actually being prepared to happen right now is the healthcare system, that it's moving towards privatization. We've already, during COVID-19, the private sector has helped immensely with regards to patients and to be able to provide care. And this is one of the things that's we don't like when anything becomes an outbreak, but it shows the sense of community that everybody puts in and they start working together. So the vision links this. It collaborates the private sector to work together. It also talks about increasing the number of registered volunteers, and we've already almost exceeded that. It was to have the minimum of 78,000 people that are registered as volunteers. And we're almost hitting that by now. And that's also one of the things that the education sector helped into, because most of our faculty have already registered as volunteers also throughout COVID-19. So it's being able to work together and improve the economy as I don't want to mention most of the things that were mentioned yesterday and in the lecture before, but the whole vision is about not to focus just on oil, and start focusing on what we have and improve on that and try to meet what's happening in different countries. We meet that and we try to excel. So, yeah.
Very good. Very impressive. Thank you. Dr. Ferris, we talked about patient experience. Well, first, before I go there, I'm going to make a commitment now that we are going to acquire a new microphone for you, because the quality of voice is not coming out very good. But we talk about patient experience. There is actually an overwhelming data, as you said, for hospitals to suggest that if you provide high quality patient experience, then the outcome is better. That is hospital infections lower, that is readmission lower, and you make more money as a hospital because now you link the experience to your star rating within the US and reimbursement ultimately. So we accomplished so far that really access, demand for change in way we access healthcare, it makes sense. Patient experience make a lot of sense, especially that it comes with better quality of care. But we'll be remiss if we finish this without talking about money, about pricing and transparency in healthcare. And this may apply particularly to the US healthcare system. It may be less relevant to countries in which the government pays for all healthcare. Then the government would regulate how much they pay or don't. Examples would be UK, Canada, and perhaps Saudi Arabia at the present time. I don't know exactly. But in the US, there is a recent Kaiser survey, actually, published very recently, that suggested that many young adults are moving away from traditional healthcare and going to those clinics provided by a drugstore and clinics provided by, urgent care type of access, because they have more price transparency and perhaps even lower pricing. So what is transparency? What is pricing? What any thoughts on that topic? I know we cannot solve it. I know that the White House have not been able to solve this issue, but some thoughts around it.
Thank you again. So you're touching on topics that are near and dear to my heart, as you know. I'm very passionate about transparency in the healthcare sector. I think the price, in the future, I'll make a prediction right now, those organizations that do not adopt price transparency will be obsolete in 10 to 20 years. They will have to come to grips with the fact that the consumer in the future will demand price transparency. Now, it may not be 100% solvable or easy for those organizations, but they have to start to move in that direction. I'll say a few things, and those might include my experience or my very brief experience with visiting Saudi Arabia, for example. There is a shift, global shift, from government-based healthcare to privatization and a mix of delivery of healthcare. And in that shift, there is an increase of consumer skin in the game, if you will. You know, the consumer will carry certain responsibility with regards to that cost of care. And in doing so, as the consumer has to be responsible for partially paying for that care, they will demand to ask, why am I paying that amount of money? And what am I expected to pay by the end of my healthcare experience? And they need that predictability in the process. And governments have realized, including in the United States, that the expenses on healthcare are ballooning to the point where 19% of GDP is not sustainable. The same is happening perhaps in Saudi Arabia and around the world. So that shift has already started, and therefore the consumer now has more responsibility, and therefore the consumer is going to ask for predictability and price transparency. And in doing so, healthcare organizations will start to compete not just based on quality, they will compete on everything measurable in healthcare: time to access, quality of care, and ultimately cost of care. So a colonoscopy may be the same colonoscopy at different venues, but if there has to be a reason for cost comparison, and a certain healthcare organization cannot double or triple the cost for the consumer based on their just whim, if you will. And therefore, I am very passionate that we need to break down the cost, we need to itemize it, and we need to provide it to the consumer prior to their experience at that organization, and allow them not to bargain the price, but to understand what they're paying for, and ultimately the value that they're getting, not just from the ultimate results or quality of care, but also how much that they have to pay for that care. And I'll say one last word about this. It is extremely important for 40% of healthcare in the United States is provided by the employer, and the employer need to budget for their following year. How much do they have to put aside for taking care of their patient population or for their employees? And that depends on the case mix index, or how the age of that mix of employees, and what are the predictable incidences of certain diseases that they will face in the next year. So that conversation is going to happen between a healthcare insurance and the employer, and increasingly by the providers, and the providers have to become more forward with those expectations going forward.
Very good. So I don't know if it's going to happen in our lifetime, watching what happened in US healthcare in the last 20 or 30 years in terms of price transparency, but who knows, there's a greater interest. Certainly, Dr. Alqurashi belongs to the other smarter technology-driven generation, so she will enjoy the benefit of price transparency for sure. I think we have about 7 or 8 minutes left, or something like that. I would like to open up for any questions from anyone.
Well, I have a question, Dr. Zein.
Sure.
If I may. And I guess really, Dr. Heba, it's to you. There's been so much talk about, especially with COVID in mind, about all of the online electronic learning that's been going on between academia, between students. And one of the, I would say, concerns has been that there hasn't been the social interaction as a result of it. And that's been somewhat of a drawback for people that need really to have the atmosphere of colleagues, of interaction. And if we really are moving, and I think it's great that we are, how do you address that? Or is that a concern that is going to be at some point just not even a concern? It will fall by the wayside because it will become the standard in terms of educating? Or will it become something more of a blended, where there will be electronic and there will still be the social interaction with the students and with the faculty?
Well, thank you for your question. I believe the answer for it that I can give right now is the direction that most educators are moving towards, and that's the blended learning that our university is already working with. It's sometimes, and I'm actually one of those people, I believe that if I don't see you in front of me, I can't really get it fully. But once you start doing it for a while, you get used to it. Unfortunately, these are the conditions that we're in right now, and all over the world, this is the only way to do it. I'm guessing everybody has seen the different videos that are moving online about educators that are sick, and they're actually, some of them in Saudi there were some instructors that already had COVID and they're sick, but you'd see him with his laptop giving his lectures to his students. A few that I've seen in the States about young children who wouldn't understand how to do their math, and then the teacher coming to their house with their distant and teaching. So we're with the current conditions where this is what we're doing. The role of all of the education sector right now is to try and check the measurements of the quality of what's coming out of this education. If the quality that's coming out is actually good, or at least acceptable for now, then the way to move forward, and most of the education sector that I've heard of, they're moving towards the blended learning, to have it online and to let the people also depend on themselves a little bit when it comes to education, but also be able to provide a sense of contact that you can actually see them and sit with them. So this is the way I think education is moving forward.
Great, thank you. Well, I have another question then on the heels of that one. And I think it actually segues nicely into the upcoming panel, which is medical tourism. Do you think that telemedicine will actually be really a augmentation and a complementary, if you will, aid to medical journalism, where somebody may find out, or on the telemedicine side, understand what they need to do, and then that will actually benefit medical tourism if they have to travel someplace to be treated?
I actually do. I remember talking about medical tourism started even when I was doing my PhD, and that was around 2011. So people started talking about it from that point of view. Telemedicine now is a fact. It's here, and I know Dr. Nizar and Dr. Maan, they talked about it a little bit, but I believe it's not going anywhere. It's actually going to stay. But with regards to tourism, I believe yes. So even in Saudi, there are some talks of it. Actually, they're doing some trials with doing that with so the doctors would be somewhere else around the world, and then to have equipment here that would actually work with him when he's working. So there are tests that are working on that. But yes, the way forward is digital. We don't want to lose the human aspect of it, because that's what makes us human. But we could humanize technology, and I believe that's where we're heading. Yes.
In fact, there are a lot of meetings, a lot of day-to-day activities that we never thought could be done in a digital way, and now are going to be extremely difficult to go back from the digital way. I think Nizar and I participate in a liver transplant meeting, for example. I find it extremely more conducive to a meaningful interaction between different specialists when you're doing it in an electronic way, where you can share, the patient's X-rays and studies, amongst others. And I couldn't agree more that this is a fact. It's not going away. People that assume that it might go away are going to be left behind, and they need to adapt to the new way forward. I think the challenge for telemedicine going forward is really the payment model, because healthcare providers need, at the end of the day, to be sustainable. And so we can go from a model of full opacity to a model where there is no return on that investment for the healthcare provider, and it's going to change the way the future generation choose what type of medicine to specialize in, to a certain extent. I'm almost certain of that.
Well, I will make one additional comment that for what Dr. Heba talked about, even beyond just education and sharing X-rays, performing even medical procedures in a digital way remotely. We have at Cleveland Clinic tested that pilot of doing robotic surgery in another country with a robot being controlled from here, from Cleveland. It is in early stages, but it probably in the future will make its way as well. You can imagine the power that would bring to places where they are unable to perform a pediatric heart surgery for congenital heart diseases, but they have cardiac surgeons who could, with the right coaching and the right control from elsewhere, make that surgery happen safely. There are models today in which we participated in one, that management of intensive care unit in another country from Cleveland, Ohio. There are incredible possibilities, still limited by somewhat technology, somewhat payment models, somewhat regulations and legal challenges, but these seems to be coming down in part, I would say, due to the COVID pandemic that made everyone realize that there's so much to gain from a more collaborative world than a siloed at least in healthcare. With that, I think we are out of time. Speaking of which, they are paging me for my first procedure, so I have to run.
You can't do it from your office, right?
Well, no, I'm going to have to do it in person for now. Yeah.
Well, thank you all. It really was fascinating. And it reminds me when somebody first brought the internet to me, I said, oh, no, this will be a fad. It will be gone in a couple of years. Well, I'm not going to say that about telemedicine. So anyway, it was fascinating and very informative.
I have to tell you a 1-second story that is speaking of those old days. Years ago, I was at Mayo Clinic. One of my senior colleagues in the department comes to me. He has a son who works in the stock market in New York, and he say, he buys stocks. He said, my son told me to buy in this company that he said it has a potential future, good outcome. I said, what's the name of it? He said, it's called Google. I said, this is true story. I said, anybody who think they are going to do well by naming a company Google is out of their mind. I'm not buying a Google. Of course, the rest.
That's why
that's you. That's why you're here with us.
Yeah, that's right. Yes.
I'll just say to you on that, Dr. Nizar, I'm sorry I didn't name one of my first children Google, but anyway.